Hello, so let's discuss about Wolf Parkinson White syndrome. It was first described in 1930, that is 90 years ago. Okay, so it was described by three physicians like Mr. Wolf, Mr. Parkinson, and Mr. White, and they described because their patient died due to tachycardia, like several of their patients died due to tachycardia. Now, these patients had normal sinus rhythm on their ECG and had like short PR interval. So this is how like whole thing started. Okay, so let's talk about anatomy now. So normally what we have is like myocardium between the atrium and the ventricle. So this myocardium is electrically isolated, so basically it will not allow any impulse to go from the atrium to ventricle directly. So there is like AV node, which is the only way like atrium can transfer the impulse towards the ventricle. So we normally a person have only one pathway. So what if like in Wolf Parkinson White they have a accessory pathway. Okay, so like there is like accessory pathway and this is the AV node. So the patient with the Wolf Parkinson White have two pathways. Okay, sorry for this. So like they have atrium, so impulse can go either via AV node or the impulse can go via bundle of Kent, which is another name of the accessory pathway. Next thing, so why this thing happens and like what is the embryological importance of this thing? So there is a myocardial syncytium. Usually what happens, this is reabsorbed at the annulus fibrosus of the AV valves, which is mitral and tricuspid. So this thing does not occur in the patient with the Wolf Parkinson White, and the remnant of the myocardial syncytium is known as like accessory pathway. So this is how like embryological importance is there of this. So now let's talk about the accessory pathway. So basically this is the most important thing of this topic. So the accessory pathways are unidirectional or bidirectional. Now the bidirectional is the most common one. Unidirectional is the less common. Okay. So unidirectional can be divided into two types. One is retrograde. One is antegrade. Okay. So in retrograde direction, so just imagine if the bundle, like the accessory pathway, only allows impulse to go from the ventricle towards the atrium, then it is known as end retrograde pathway. So if and another one is if the like pathway, accessory pathway, allows only the impulse to go from atrium towards the ventricle, then it is known as antegrade pathway. Okay, so and the another one is a bidirectional. So in bidirectional, impulse can go either way, like from the atrium towards the ventricle or from the ventricles towards the atrium. So this thing like this is like most common one in amongst all. So another name of the retrograde pathway is a concealed pathway. Okay. Now the major difference between this like two unidirectional pathways is the delta waves. So delta waves is not present. So delta waves is not present in the retrograde pathways, and the delta waves is present in bidirectional one also, and the unidirectional one which is antegrade, which is only pathway which is allowing impulse from the atrium to the ventricle. So there is delta waves present here and here. Okay, another difference is about the AVRT. This is a type of tachycardia. This is atrioventricular reentrant tachycardia. So what do you mean by reentrant tachycardia? So in the reentrant tachycardia, just imagine an impulse from the atrium towards the ventricle goes from the AV node. Okay, and that same impulse goes back towards the atrium through the bundle of Kent or the accessory pathway, and the cycle begins of tachycardia. Okay, so this kind of tachycardia which in which the AV node is transferring impulse from the atrium to the ventricle, it is known as orthodromic AVRT. Okay, now the another example is that if the impulse goes from the atrium to the ventricle through the accessory pathway and goes back towards the atrium through the AV node, and the cycle occurs like this, in which the AV node transfers impulse from the ventricles towards the atrium. It is known as antidromic AVRT. Okay, now this is like in retrograde, it is also known as concealed. It does not have delta waves and it causes orthodromic AVRT. If the pathway is antegrade, it do have delta waves, it will cause antidromic AVRT. If the pathway is like bidirectional, it delta waves is present, and it can like orthodromic and endodromic both can occur. Okay, so this is like simple. So how to differentiate between the WPW pattern and WPW syndrome? So it depends like on the arrhythmias. Like arrhythmias are present or it is absent. So if the patient do not have a history of arrhythmia, it is known as WPW pattern. Just imagine like a patient come to you without any history of any arrhythmias or any syncope or any chest pain, and has a pattern of and has a ECG pattern of WPW, then you can say that that patient has a WPW pattern. But if a patient comes to you who have a ECG pattern of like short PR, long QRS, and a delta wave, and has a history of syncope or something like that, okay, which suggests that patient had past medical history of any kind of arrhythmia, then you will say that the patient has WPW syndrome. Okay, so this is like ECG criteria for WPW syndrome. Okay, like WPW pattern, and usually for diagnosis you just need a ECG. Okay, and like rarely you need a electrophysiological study. Another thing, like the what about the like history, like in the history you should ask the patient about syncope, like any like syncope where he felt like palpitation and he had a syncope, something like that, like lightheadedness or something. You can also ask about like chest pain, which can contribute to the palpitation or arrhythmia, or the patient do have any family history of sudden cardiac death, because like in WPW patients, they do have like 5% of patients do have a history of sudden cardiac death in their family. And let's talk about tachycardia. So tachycardia and the WPW syndrome can be divided into two types, which is like requiring accessory pathways, and which do not require accessory pathway. So the tachycardia which requires accessory pathway is orthodromic AVRT and antidromic AVRT, and the tachycardia which do not require accessory pathways AVNRT, AFib, A-flutter, and VFib. So basically, this is all you need to know about the Wolf Parkinson White, and remember, you also need to remember the ECG pattern of WPW, which is short PR, delta waves, and long QRS. This is the most important thing, and the types of accessory pathway. Thank you.